Hi, good afternoon, everyone. John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn Thursday afternoon. Today, we are really excited to invite two of our premier gynecologists on staff to give us a talk about evaluation of abnormal uterine bleeding. Next slide, please. So we wanted to just tease the next week's upcoming Lunch and Learn. It's going to be hip pain in an athlete or the pseudo-athlete. Dr. Ethan Healy will give his talk. And then the following week, because of the holiday, we will come back after the new year. So that'll be the last talk for the year. As you know, all our talks are posted up on YouTube as just searching Newton-Wellesley Medical Group Lunch and Learn, and also on our intranet, Newton, and you can just look under there. We also wanted to make folks know about our other learning opportunities here at Newton-Wellesley Hospital, our APP Grand Rounds, which is sponsored and brought on by Amy Israelian. These are great topics once a month on Tuesday. I believe it's the second Tuesday of the month, if that looks correct, yes. And this is something that can be put in your calendar if you just email Amy. These are great topics, all given by our APPs at our hospital. And also we wanted to tease, of course, our Wednesday 8:30 Medical Grand Rounds is available. Also, that's a great series that Dr. Larry Freeman, Department of Medicine, puts on as well. As we continue to move into surge and high volume in our emergency department, I thought it was important just to put up our slides about our walk-in availability here at Newton-Wellesley Medical Group. We have our Waltham Family Medicine, which has a walk-in arm that is open Monday to Friday, 10 a.m. to 6 p.m. And you can see the services there. And as it says, it's a walk-in. You do not need to be a member of that practice. Patient does not need to be a member of the practice, and could be anyone there. And it is a walk-in copay as opposed to waiting in the emergency department and getting an emergency department copay. Next slide. Of course, we have our orthopedic walk-in as well, which is open 7 days a week. Injuries on the soccer field on the weekends for pediatrics and adults. I often get that question. There are folks there who can see you. We have a full casting room there, and full x-ray services are right there. We can take care of anything. Again, that's walk-in 8 to 8 p.m. Monday to Friday, fully staffed, and on Saturday and Sunday 8 to 1 p.m. So please take advantage of that. Keep yourself out of the keep your patients out of the emergency department. Keep them away from large copays, and also help manage the surge and help our emergency department take care of the sicker patients that they need to. Next slide. Lastly, we know these times are tough and very busy. We also, all physicians and APPs on staff are available, have this available to them, which is a physician concierge service. All you need to do is enroll at communities.circles.com, and they will find services that you may need. This is free of charge. All you have to do is sign up, use the welcome code NWH, you get a full year. People have used this, including myself, for auto body repair, for repairs around the house, lawn services, snow removal services. And what they will do is put you in touch with companies in your area that have good reputations, so you don't have to do all that footwork. So please go ahead and take advantage of that. It's no cost to you for a full year. Next slide. And I believe that's it. So Heidi and Diane, take it away. Thank you for coming.
Thanks, John.
Thank you, John. Good afternoon, everyone. And thank you to John Snyder and Audrey and Jane for helping us with this presentation and inviting us today to speak to you. Today, I'm here with Heidi Engel in Weston in our office to speak to you about abnormal uterine bleeding, and are affectionately known as Spotty Dotty. This is our group. We're a 4-woman gynecology practice in Weston, and Judy Hondo, Martha Ehrman, myself, and Heidi Engel. And here we are with our vaccine. So we're located about 12 minutes down the road from Newton-Wellesley Hospital in Weston, and we're in a medical office building, which is actually owned by partners. And we have primary care as well located in the building.
All right, we're going to jump into it. So we're here today to talk about abnormal uterine bleeding. And starting with the basic definition, AUB is menstrual bleeding that occurs outside of the normal range. And issues can include absence of menses or amenorrhea, periods that are irregular, periods that are excessive in length, typically more than 10 days gets our attention in the GYN world, intermenstrual or breakthrough bleeding, and most disturbing to our patients is heavy menstrual bleeding. HMB is difficult to quantitate in study settings and in the literature, So in the GYN world, the accepted definition is a volume of menstrual flow that interferes with the patient's quality of life, be it physical, emotional, or social. So if our patients are bothered by heavy flow, we as their providers need to be aware of it. Probably a lot of you don't see adolescents. I'm guessing some of you have adolescents in your home. So abnormal bleeding in the teen would be defined as periods that are more frequent than every 21 days or less frequent than every 45 days. And these issues get people's attention, but are exceedingly common. Diane said this fall when she was prepping for another talk that she always likes to learn something new. And the new thing that I learned prepping for this talk was that if a young woman starts her period at less than 12, within a year, half of her cycles are ovulatory. But if a young woman starts her period after age 13, it can take up to 4.5 years for her menstrual cycles to have half of them be ovulatory. So it is not uncommon for it to take up to the 6th gynecologic year or the average age of age 19 for periods to regulate. So that's some reassuring information that we can share with our teens and their parents. Seeing young women in the office is something that we want to give them a lot of time. So patient comfort is exceedingly important, but also comfort of the parents. Patient privacy is important. Based on the feel of the patient and her parent, we'll typically see the patient, the young woman, with a family member, but also give time for the young woman to speak with us privately. And we may see the patient and her parent initially together or the patient initially on her own. So we'll go with the feel for that, just judging the comfort level in the room. The primary focus with evaluation of young women is to focus on the history, and we may not do an exam at all unless the bleeding continues to be problematic. Basic lab work is shown on this slide. We will typically update a blood count and a thyroid study. I almost always get a von Willebrand panel in my young women patients who are having heavy menstrual bleeding. The formal teaching is that in this age group, you should always do a pregnancy test and always do STI or STD testing. But if you have a patient who is terrified to be in your office, swears up and down that she's never been sexually active, if you insist on this testing, that can kind of be a break of trust. So my recommendation is to consider those tests, but use your clinical judgment always. Next age category that we see are women in their middle years, ages 20s through 40s. In this group, you always want to consider the possibility of pregnancy and always consider the potential of infection and be quick to do STI testing, particularly for chlamydia and gonorrhea. Almost all of our patients in this age group will do well with the basic workup of a pelvic exam, updated blood work if needed, and we will commonly do an ultrasound evaluation as well. My primary teaching point with this age group is be really mindful of where the woman is in her cycle and what the potential is for pregnancy. We never want to do any diagnostic procedure where we instrument the uterus that could interrupt a pregnancy. Not to be flip, but sometimes for both our patients and for the providers, perimenopause can be the greatest challenge of all. And we have to take into mind what various symptoms the woman is undergoing as we make a plan for them. In this age group, you still need to consider the possibility of pregnancy. I have had women at age 50 call me in a panic with a positive pregnancy test. No matter what you know of their social history, you still want to ask them if they'd like to be screened for infection. Again, most women in this age group will do well with a pelvic exam. We will typically update blood work, and we almost always will employ an ultrasound evaluation as well. I would say in this age group, we're much more likely to consider follow-up procedures such as an endometrial biopsy or a biopsy in conjunction with office hysteroscopy. And management will be very much geared based on the woman's symptoms, whether they're having a lot of vasomotor symptoms, or maybe it's just heavy menstrual bleeding, but their partner's had a vasectomy. So the history, again, in this setting is key to management. I wanted to say something about adenomyosis because I'm sure a lot of you see this comment on the ultrasounds that you order on your own patients. I explain adenomyosis to my patients as what's shown in the graphic on the left. So basically tissue that's supposed to just be in the endometrium or lining the uterus is embedded in little nests in the muscle of the uterus. And that's what's seen on ultrasound. Incidence is in 20 to 35% at least of women. If you do a pelvic exam on women with adenomyosis, the uterus commonly feels softer than average, almost like a pregnant uterus. It can feel more globular than it typically would. It can almost feel like a fibroid is present. So this is a common problem that patients will have raised, especially after they have an ultrasound study. The next graphic is a Mirena IUD, and I wanted to show that because the Mirena is the only progestin IUD that's FDA indicated for heavy menstrual bleeding. And it can help a number of women with adenomyosis. The Mirena can actually shrink the overall volume of the uterus to include in women with adenomyosis. And 80% of the time in all women can help bleeding. But it doesn't make the adenomyosis go away. So the somewhat blurry picture to the far right is of a laparoscopic hysterectomy. And if women continue to have bleeding issues with adenomyosis, that would be the definitive therapy. We always need to consider, no matter what the age of the patient is, risk factors for abnormal pathology. EIN is endometrial intraepithelial neoplasia, and obviously such a mouthful, we just use EIN, but consider it to be precancerous changes of the uterus. And the primary risk factor in the patients that all of us see for EIN or endometrial cancer is an elevated body mass index. So the risk is fourfold higher in women with a BMI greater than 30. So we always want to be thinking about the potential that abnormal pathology is something we need to detect. Two quick graphics. The Pipelle is the tool that many of us use in the GYN world for an endometrial biopsy. The diameter of the tip of the Pipelle is 3 millimeters. So in most settings, you're able to advance that through the cervix and into the uterus. And it's crampy for patients, but typically tolerable. And then the graphic on the right is the office hysteroscope that we use here at GYN Partners. Not perfect for all uterine sizes, but again, the tip is small. I believe it's 4.3 millimeters. It's a flexible catheter, and most people will tolerate it well, and you can get a great assessment without going to day surgery, especially during pandemic times. And my talk, it has been about evaluation, but I wanted a quick slide to show some GYN favorites in terms of management in the age groups that I've discussed that some of you may not have heard about. Low estrin is the only 10 microgram birth control pill on the market. There's no generic equivalent, but it's popular with patients who are worried about hormonal side effects because it's so low dose. And then the vaginal rings that are that contain estrogen and progestin, like a birth control pill, but the delivery system is a ring in the vagina, are also low dose. So NuvaRing's been out for many years, has 15 micrograms of estrogen. The newcomer is Annovera. It's one ring for an entire year with 13 micrograms of estrogen. And Listetta is something that I think all of us in our office use more and more for women who can't or don't want a hormonal method. This interrupts fibrin degradation and can be used for heavy menstrual bleeding. And now to Diane.
Thank you, Heidi. So next we're going to speak about postmenopausal bleeding and the evaluation. The definition is 1 year after no menses, any spotting or bleeding, brown or red, is abnormal. And also the cessation of menses occurs most of the time after a loss of ovarian follicular activity. So most of the time, if someone comes in complaining of spotting or bleeding, it is benign, but 10% of women with postmenopausal bleeding will have uterine cancer. The most common cause of postmenopausal bleeding is endometrial atrophy or vaginal atrophy. You can think of it like blowing your nose when your nose is really irritated. Sometimes it will cause a little irritation, and that happens with women with heavy lifting or working hard or exercising, they might pop up blood vessel, and then they see it on their underwear or in a panty liner. Other times you can see postmenopausal bleeding with hormonal therapy, and also with uterine pathology, endometrial hyperplasia being a common one, or proliferative endometrium, which is just early stimulated endometrium from estrogen, or a disordered endometrium, meaning it's out of phase and it's not getting counterbalanced by progesterone. And 10% of women who present with postmenopausal bleeding will have uterine cancer. The other common causes would be uterine polyps we see, and the photo is a hysteroscopy photo of a large endometrial polyp, but we can't forget the basics, like cervical cancer can present with spotting, vaginal cancer is more rare, and other infectious causes, cervicitis, endometritis. And let's not forget that some women will say that they're bleeding, but they don't actually know where it's coming from. And it could be from the bladder or urethral caruncle, rectal hemorrhoids. And then also a common thing in postmenopausal women is to have these little vascular angiomas on their skin, and sometimes those burst and present with a little bit of spotting. And then unusual presentations of vulvar cancer, melanoma, and rare basal cell can also present on the vulvar skin. So what do we do for the workup? Let's start with examining the patient, looking at the vulvar skin, etc., doing a speculum exam, looking for a cervical polyp, and then the standard of care, American College of OBGYN recommends either evaluating the endometrium with either an endometrial biopsy, a transvaginal ultrasound, or a formal D&C. So the ultrasound can, from a transvaginal point of view, estimate how thick the endometrial lining is. And through many large studies, the evaluation of the endometrium showed that if the lining is less than 4 millimeters, we can decrease the, we can pick up less endometrial cancers if the lining is less than 4 millimeters. So the other way to evaluate is a hysteroscopy, which Heidi showed you what we use in the office. It's very easy to do, and we can grab a biopsy at the same time that we do a hysteroscopy. If we do find with a biopsy that the patient has endometritis, we can treat with antibiotics. We can resect a polyp with a hysteroscope. We can treat atrophic vaginitis or endometrial atrophy with low-dose vaginal estrogen. And we can treat endometrial hyperplasia with progestins or a formal D&C and scrape the lining out, or down the road, if she doesn't respond to treatment, a hysterectomy. There was a small prospective study done in India recently, looking at 76 women who present with postmenopausal bleeding, and looking at an endometrial thickness of greater than 5 millimeters. Mean age of presentation was 57. And what did the pathology show? Atrophic endometrium in 30%, which is similar to what we have in our practice, proliferative endometrium in about 27%, and a little bit higher risk of cancer in this group, about 16% had endometrial cancer. So let's speak about endometrial cancer. It is actually one of the cancers in the United States that's actually increasing. And one theory is that because of obesity and estrogen, that the endometrial cancer is increasing. So in 2019 data, 61,000 newly diagnosed cases of endometrial cancer and about 12,000 deaths to endometrial cancer in the United States. It's usually broken down into two types. Type 1 being the estrogen stimulated endometrioid associated cancers, obesity, tamoxifen use, we'll see endometrioid. adenocarcinoma. Type 2 is what's considered non-endometrioid, and these are serous carcinoma, mucinous serous adenocarcinoma, and carcinosarcoma. So these are called type 2. They're a little bit harder to pick up on ultrasound. Some of the risk factors we discussed about endometrial cancer and also EIN that Heidi mentioned: obesity, tamoxifen use. About 1 in 1,000 patients will have endometrial cancer from tamoxifen use, a good statistic to remember. So increasing age, early menarche, late menopause, so more estrogen around longer, and some medical conditions that are associated with endometrial cancer, which I'm sure you see a lot of: hypertension, diabetes, and then family history of hereditary non-polyposis colorectal cancer. And then, of course, unopposed exogenous estrogens. The thing that I learned preparing this talk was something that's been brought to our attention over the last 3 years is the racial disparities that's occurring in our country with the presentation of endometrial cancer. Black women in the US with endometrial cancer are more likely to be diagnosed with an advanced stage of disease, and this is independent of their insured status or access to health care. And the vaginal probe ultrasound endometrial thickness evaluation in Black women underperforms, and it's thought secondary to the higher prevalence of fibroids in this population, and also they have a higher incidence of this non-endometrioid cancer, which sometimes can be a focal lesion and sometimes can have a very sort of insidious presentation, less than 4 millimeters on the ultrasound. So there was an article in JAMA Oncology which looked at these racial disparities and trying to find out why this is occurring. And so they did actually do a simulated cohort study looking at SEER data from 2012 to 2016, all comers who had endometrial cancer. And they were able to retrospectively look back at the ultrasound data and the histology data, and found that the transvaginal ultrasound endometrial thickness prompted biopsy in only 47% of Black women, compared with 87% of white women. And over 4 times more cases among Black women with endometrial cancer were missed compared with those among white women, based on the difference in the performance at the guideline recommended 4 millimeter threshold. So thinking carefully on this, in the case of endometrial cancer, which, as I said, is increasing in our country, the long-standing mortality gap between Black and white women mandates that we think carefully when we're talking about the cancer care continuum and evaluating women, specifically Black women, with the goal of creating equitable performance of our tests and workups. So postmenopausal bleeding should always be investigated, no matter how minimal or non-persistent. So if someone says they come in with 1 spot of blood in October and you're seeing her in January, that is enough to activate a workup. So just remember, in summary, that a woman with postmenopausal bleeding, in general, 10% have a chance of endometrial cancer being present. And that the evaluation using transvaginal ultrasound can be combined with an endometrial biopsy or a formal evaluation with the DNC to rule that out. And we're hopefully left time for questions. Thank you very much.
Yeah.
Thanks, you guys.
Thank
You guys, if people on the call can throw some questions in the chat box or jump in if you'd like, because we do have 5 minutes. One thing I was wondering, maybe Diane, you can answer this question about, a lot of times as PCPs, we get the call where maybe the woman's been worked up for postmenopausal bleeding and she's having fairly heavy bleeding now. And this is one of those things I remember from residency training, which is you can use estrogen or you can use progesterone, and you can use NSAIDs. What is your favorite kind of combination to slow the bleeding down or to stop it, in a sense, and what kinds of things should we be on the lookout as PCPs before they get to see you guys as gynecologists?
Okay, so John, is this a postmenopausal woman?
Yeah, that's correct. Yeah.
And the workup was atrophy?
I'm sorry, perimenopausal woman. So if she's in
Oh.
perimenopausal, just having heavy bleeding.
Heavy bleeding, and she's had a negative biopsy.
Yeah.
So what's our sort of go-to?
Yeah.
So emergently, if you've ruled out cancer, progestin usually acutely works really well. And then also, if they're not on hormones, our go-to is tranexamic acid, Lysteta, because that can work in an acute situation, and it's FDA approved for heavy bleeding. So in an emergency, 800, there's 650 milligram tablets. They take 2, and every 8 hours for 3 to 5 days, 5 days max. And that can contract the blood vessels and give you a good result. Control the bleeding. Fibroids will be controlled this way. If they're on hormones, then it's a slight increased risk of a blood clot in their leg. We have not seen that, but that's what it's in the package insert. So then if they're already on hormones, then we use progestin. I don't know, Heidi, what do you think?
Exactly what you said. For our board recertification, there was a great Lysteta article recently. So apparently Lysteta has been available in Sweden since the 1960s. I never used it until it became so popular to use IV for OB hemorrhage. So when I was doing OB, we would hang it a lot for heavy bleeding at delivery. And then I got more comfortable using it in oral form. There is an FDA contraindication. You're not supposed to use it in the US for women on hormones already or who are felt to have a higher risk of thrombosis, but those contraindications are not present in other countries. So the assumption now in Sweden, where it's over the counter, that a lot of people probably on hormones or birth control pills take Lysteta in addition. But yeah, as a generalist, I wouldn't recommend going off label, so to speak. So other than Lysteta, I wouldn't give estrogen in a perimenopausal woman because I would be worried about pathology. But I would definitely use progestin, and between Provera, Megace, Agestin, which is norethindrone, and potentially ramping up doses if the bleeding's continuing. We do a lot of that. But these are the kind of women that we try to see soon, because if they have fibroids, it's an issue. I mean, it's just so hard to figure out where it's coming from. So we always try and get these people in, ideally in a timely fashion, so we can start sorting it out.
Sure. And then, going back to your point about the adenomyosis, which is well taken, and using Mirena or its like for it, do you find that also decreases sometimes the crampy pain that goes along with the adenomyosis, or just the bleeding?
Both, in my experience. So if I'm counseling somebody about a Mirena, I tell them the procedure itself is crampy, and they can be crampy early on just with the new foreign body being placed in the uterus. But over time, especially if they're among the lucky ones and their flow lessens, then typically as the flow's lessening and the heaviness is lessening, the cramping lessens along with it. I think the heavier the bleeding, the blood kind of irritates the uterus. The more you bleed, the more you cramp, you get into that vicious cycle. So if the Mirena is helping the bleeding, usually the cramping lessens along with that.
Thanks. And Sally wants to know, why not use low dose OCPs if there's no contraindication, if under 50, to manage the perimenopausal symptoms? What do you guys think about that?
All the time.
All the time.
All the time. And that's why I showed that picture of low estrogen and even the vaginal rings, because so many people have vasomotor symptoms, and the estrogen and the low dose pill will help with that, but they're having irregular bleeding or heavy bleeding, so the pill will help with that. You have to counsel them more about the risk. I think the primary concern, other than the stroke blood clot risk, is lifetime risk of breast cancer with any hormone use. But we use low dose pills all the time. And in healthy women, sometimes up until 52, kind of last age that we'll use a low dose pill usually is about 55. They have to be obviously super healthy non-smokers and well counseled, but we use them all the time.
It's a great question, great point. Thanks for that. All right, we're at the top of the hour. Really appreciate you guys coming on and giving us this brief talk. And of course, they're available to see patients for you. There's a nice, oh, there you go, nice happy holiday picture from them. We really, Newton-Wellesley Medical Group, hope everyone has a great weekend. And we'll see you all next Thursday for the last talk of the year for us on hip pain. And don't forget about the other talks on Tuesday with the APPs and Wednesday mornings with the Department of Medicine. Heidi and Diane, thank you so much for being here.
Okay, thank you.
Yeah, thanks so much, John.
Okay.
Thank you, Jane and Audrey, too.
Okay.
Thank you for saying
Bye-bye.
that, Heidi. Bye.
Thank